Thank you. It's very generous, and I do. You presume when you say that we can take complex topics and explain them clearly that we actually have an understanding of those complex topics that's sufficient. And sometimes the information's moving fast enough that it's difficult to keep up with. I've been in measurement for a long time because I did engineering before medicine, and I've been a firm believer that you can't fix anything that you can't measure for a long time. And that was a relatively new thing when I was in medical school, that we would measure anything. And I'm probably dating myself now too, but now it's the way we talk about the world. But even so, as a faculty member at a medical school, students aren't learning how measures are built, or what a value set is, or what the quality data model is. We're trying to rectify that in our curriculum, but we need a workforce of people, nursing, physician, everyone, social work, everyone in the system, who not only can do the work that they've been trained to do, but they understand how that work is going to be measured. So I just put that out there as an aside, but until we have that, we're not going to have a workforce, I don't think, that can really understand what the next needed action is in response to a measure result. So I was told the topic was this. I have one table at the end that really focuses on it, and I'm going to try to build up to it. You guys may remember, if you were in my presentation yesterday, this slide where I was trying to make the point that measuring around the belly button is a better way to go, from my perspective, than measuring around the doctor or around the specific practice. Because when you measure around the individual patient, you resolve this problem of having the same 4 people have very different results in the measurement. And in fact, not being able to roll this up or group these results, right, so that we can serve different perspectives on the measure. And I think probably everybody who's spoken on this topic today would recognize that, or would agree that we want to gather data once and use it many times for many purposes, right? We don't want to gather the data one time for this purpose and then go bother the doctors and the clinics for another set of data to do another thing, and so on and so forth. And this method, we think, of focusing on measuring around the whole patient, does a good job of meeting many perspectives of measurement, whether it's the payer who wants to know about their patients or the practice that wants to know about their patients. Just by grouping the individuals together in the right ways, we can get the measure sorted out. And you recall that I talked about the notion of a trusted third party. Kevin was just talking about the Minnesota Community Quality Measurement Initiative, which is a very similar concept, a much earlier version that's been a model for us in this space, and the notion that claims and clinical data can be brought together in one place is one advantage of this model, and also that it's jointly governed by the payers and the providers and the patients and employers, frankly, and that the measures are chosen and the methods of implementing those measures are also chosen. So you guys, if you've worked in measurement, know, and if you haven't, you should understand that no matter how prescriptive the measure definition is, no matter how algorithmic it is, there are dozens of editorial decisions that go into each implementation of that measure. Choosing whether this checkbox being checked means the mammogram was done or not is something that the vendor and or the practice gets to do. And that adds some variability to what we're doing. It adds a lot of variability potentially to what we're doing. So one of the advantages of this trusted third party level, of pushing the data to this level and measuring at that trusted third party level, is that we make one set of editorial decisions across the whole community, right? So the stakeholders who measure, or who care about the result of that measure and who want to pay based on it or get paid based on it, can count on the same set of editorial decisions being made. And by editorial decisions, I mean, well, I can go into some specifics in a moment, but for example, one we see often is if we're calculating mammography rate, the files that we get from practices on a regular basis rarely have the appropriate coding for mammograms, but we do get the mammography reports from all the imaging centers, right? So there's an indicator that the mammogram was done. We have the claims data, which has a procedure code for the fact that a mammogram was done, and an editorial decision that the community must consider is, and this doesn't meet the NQF definition, I want to go up front and say that, but the community might consider, gosh, everybody's going to perform at 1 to 2% on mammograms if we base it only on the EHR feeds. But if we add the reports on mammograms and we add the claims data on mammograms, and of course don't double count those, then we can get folks to what we think are about the right levels of performance. Does everybody want to do that? Yes, of course everybody wants to do that, because in reality what they want is the truth, not just what the measure spec says. They want the truth. And so that's the kind of editorial decision that goes into every community's, or should go into every community's work. Right now, that editorial decision making is happening, if you're measuring at the EHR by EHR level, it's typically made by the EHR vendor when they code up the process of extracting the data and normalizing it. So in any case, I just reiterate this as one of the advantages of measuring around the belly button based on data extracted and aggregated at a community or whole patient level. And you guys remember that the ability to report this on, if you were there yesterday, where I was pointing out that the ability to report, measure once on everyone and report for many different perspectives of interest. So the provider is interested in being able to close gaps in care and know how they're going to be performing by the end of the year. So drawing a box around their patients who are in numerators and denominators gets you there, right? Same thing for another provider or even specialists, which I know accountable payment models have really struggled with figuring out ways to incorporate specialty care, and we think this is a good way to do it. If the specialist touched the patient, then the patient's in their count here in the program. And frankly, if they only touched them once and sent them back to the PCP, then this should incent them to call provider number 2 and find out which one of the two of us is going to close the gap on this patient that's in the denominator only here. And then, of course, I've always referred to the golden rule. The payers and the employers need to know not just how to practice or a doctor's doing, but how is this measurement happening on my people, on my patients. And then public health is a critical stakeholder as well. Oh gosh, that may be too small to read. One of the things that we put on the table by advocating for measurement around the whole patient, and those of you in the room who are on the same page with me, we need to think about the chain of evidence from the source at which the data was gathered all the way through to the point where we calculate that measure performance. And that chain of evidence needs to be intact. We used to talk about that in the emergency room if there was a case that was going to go to court, for example, because there was violent crime or something, and protecting the chain of evidence. And I apply it here to the data. Because the gathering of data in the usual process of care goes through all these steps when it gets into our systems at MyHealth, for example, and becomes a quality measure. And we have to pay attention to those. But I will tell you that not all these steps are in our control, right? The doctor who's seeing the patient, or the nurse who's documenting, or the social worker who's documenting, has that green box, data entry. Entering the right data in the right field, recognizing the label on that field, and knowing that it's a number and not, or that it's pounds and not inches and so on, and putting that data in correctly. No small step, but it gets done maybe 80% of the time correctly, maybe 99%, I don't know. The next step in the process of data gathering is really mostly up to the EHR vendor, or whatever the point of service information system is, right? And at that point, we start to see some variability being introduced because different vendors do things in different ways, right? And so we have found in our CCDA files a fair amount of variability about the way vendors handle different things in their coding. And indeed, in my own EHR at the university, where I see patients occasionally and have a massive list of unsigned charts that I need to get back to and sign, I see that there are about 70 checkboxes in the template for a new patient visit that are relevant only for the measures that I need to calculate. And so I teach medical students, and I'm always finding that the student says, I just kind of ignore those because I didn't know they meant anything, or they were important for anything. And so those are issues that are sort of shared, I think, between the provider and the EHR vendor itself, because it's not wired very intelligently into the workflow. So we've had to sort of brute force stick a checkbox in there that attests that I did something. Like the med list is on the screen and I'm looking at it, and yet I still have to check a box that says I looked at the med list. Are you kidding me? Why do I have to do that? So there's that step in the process. And then the blue boxes to the right kind of become our work. at the health information exchange level. And it's a lot of steps, you know, from data transport, the data extraction, the transformation of that data to put it into the right fields in a data structure. And then we load it to our central data repository, and then we do additional code normalization where we process that and try to identify the codes that match. And then we do some manual code normalization when things break, and we need a variable that we're not finding for a particular measure. And then we finally have the way we present the data can be misleading or mischaracterize the results if we don't present it just right. So we have to get this whole chain correct in order for quality measurement, from my perspective, to be valid. And I didn't really even talk about the methodologic issues that Kevin and I were exchanging discussion about earlier, like statistical significance, and really understanding at what level the result is true. So the stack and the obligatory spaghetti diagram here of our technology stack and process is take the data in, transport it via different mechanisms, take that raw data, classify it, we classify messages, we identify and characterize data into realms like observations or meds or whatever other realm of data. We use UMLS on the back end to tie everything to as much as we possibly can. And then once we've classified the message, it goes into our reporting environment, MPI, of course, clinical data repository. And then we have our user-facing products on the left there, and then we also have the ability to send this data in formats requested by third-party applications. Maybe somebody's hired a vendor of their own to do the work, and so we can port data to them as well. So you remember I showed yesterday this chart, which we created by taking all of the clinical data that's fed to us and all of our normalization efforts, that mostly auto-normalization for this chart. You know, not a lot of manual work yet when this chart was created, and looked at how often a source had sent us a code, or whether a source had sent us a code to trigger a specific value set. These are probably too small to read, but like the top one there is acute myocardial infarction, and then allergy to beta blocker therapy. You know, these are value sets, and maybe I should go over the quality data model real quickly. So the notion of the value set is that it's a concept, and underneath it are all the codes that indicate that that value set is true. So acute MI is all the ICD-9, ICD-10. It may have some SNOMED codes in it even that indicate that this patient has had an acute MI, and there are about 770 value sets that are relevant for the current set of ECQMs. And of note, I will point out that there's not really good coordination of the value sets. There are, I think, 14 of them that indicate face-to-face office visit of some kind, and they're all different sets of codes, and it drives us crazy, just to be quite blunt. But what you see here is across the top a bunch of different EHR vendors, and then each of the colored dots is a source feeding our health information exchange, and whether that source has triggered that value or not. The data for this, you can tell pretty dramatically the difference when we get a C-CDA versus just an HL7 feed, right? So let me find a column here that's an HL7 feed. You see Healthland there. It's about 1, 2, 3, 4, 5, 6 in from the right. It's a very sparse column. That's HL7 feeds only. And then you see GE there, Centricity in the middle, or GEMS, the one next to it, which is our Heart Institute runs that EHR. That's a CCDA, and you can see many more of the value sets are being triggered by that kind of data that's coming in. So it's a richer source of information for us. So I just point this out to say the first thing, and I think Kevin was alluding to this too, is visibility into knowing what's going on in your data and seeing this. And so we provide this to our sources for their own feed to say, here's how many value sets you cover, and here's how many you don't, and here's the gap we're going to have to work together to fill in to make sure that you can cover the needed value sets. Oh, we also subset this to specific measures, right? So that if you're only interested in blood pressure control and hemoglobin A1C for a particular contract or for a particular quality improvement program, we limit it down to the dozen or so value sets relevant to that, and you can therefore have a manageable workload to focus on. As I said yesterday, we find that the claims data is really important, but based on my mammography example that I gave a moment ago, we also find that we're having to make editorial decisions to include claims data in NQF certified clinical quality measures, right? We're having to alter the spec a little bit to be allowed to include those claims measures. But we find that it's critically important. And just to kind of give you a perspective on it, we think that the claims data brings much better indication of the timing of things, when something began, when something ended, which is critical for these measurement windows to work, than the CCDAs do, which we usually get. We do not get QRDA ones, so in full disclosure, we just, that's not an animal that gets sent to us because most practices have to export that manually. It's just not available. So we don't use QRDA ones in this process, but I'll talk more about that in a moment. So our most accurate measures can happen where there's maximal overlap between the claims and the clinical data, and we can triangulate on the result. Like, oh, I see we have a mammography report, I have a mammography CPT code, and those are both true, and the data service matches. Done. That was a numerator generating event for this mammography measure. You remember I showed this slide yesterday too, but I wanted to go into a little more detail on it today. This is, in my estimation, that pie chart is one of the most powerful ways to communicate how important it is to do measurement at a patient-centric level rather than a practice or doctor-specific level, centric level, because you can see how many different sources, clinical sources, contributed to this patient's measurement. But in the bar above that, you can see the value sets that were triggered. See the diastolic blood pressure, essential hypertension, office visit, and systolic blood pressure there. And then you see the measurement window in gray on the end with the dashed lines. So while there are indeed variables on to the right of the measurement window, and there are variables triggered to the left of the measurement window, they are not considered in this measurement. And I can mouse over each of those dots to tell me what was the diastolic blood pressure that was triggering this measure, and look at the most recent one, for example. We also have, within this tool, you can see at the top the data preconditions, and that's a term that I'll correct at some point when I figure out a better word for it, but it basically is all of the little triggering steps in the measure. I mean, if you really to write out any one of these measures, you're going to find it's a very long, multi-page branching tree of logic where patients can, sort of like that game Plinko, they can move from one decision node to the next decision node and wind up in various buckets at the bottom of the measure. Some excluded, some in the denominator only, and some in the numerators. And so that list on data preconditions helps us to decide, well, what was the reason the patient fell out of the numerator on this measure? And this is the level of visibility we have to get into to convince providers that we've done the right thing in building the measure and that we're doing it accurately. So that's an important tool, and we continue to expand on it and are looking for other ideas about how to present this in a better way, if you have any. So our measure engine, our data feed engine on the back end looks like this, and you can see all the charts I can monitor to see how much data is coming in and what's the decomposition time on the CCDAs as they come in, or the HL7 messages. Gosh, that's going to be too small to read, but this is a code normalization tool that we put together, and what it does is any bit of knowledge that we get in any form of message, whether it's claims or a CCDA or an HL7 message, any bit of knowledge gets broken out into a 3-component item, which consists of the code set name, the code itself, and the string or the text or whatever came in to indicate that that code was relevant. And so what this chart there in the original column shows is a bunch of those 3-segment messages, and I can look at them by source, and I can look at them by code system and realm. And what this tool lets me do is, for example, I've found a cancer center there, and I looked up SMOK, just the string SMOK, find all the ways they're coding smoking. And usually there are 50 to 100 different ways that a source is coding smoking, even if we're getting a CCDA. And so I'm able to go in and pretty quickly choose one, and you see the far right is called confidence, and that confidence indicator tells me, was it an exact match that happened automatically, or was it done by an editorial process? And I should say, there are millions of rows of these that could be coded. We only focus on the ones that matter for measures, right? We go in and code the ones that matter for measures. But if I choose now a smoking item that was missed, you see here on screen, it shows me the potential resolving code, and then on the right side, and this is what's really important, I think, about doing this at a community level, it shows me every other system and source that uses that same code to indicate that same concept, right? Because if we're going to do measurement, we want to do it consistently across everybody in the community. So that's the way we approach that. Now, finally, I'll tell you about my perspective on CCDA versus QRDA1 versus QRDA3, and then Kevin and I can discuss it. But so here's my thinking. First, the frame of reference, right? The CCDA is individual patient and all data, or all data in the meaningful use data set anyway. We could expand that quite a bit. The CCDA is an architecture, right, that can hold lots of stuff. In fact, the QRDA1 is a form of a CCDA. It's just a very tailored form of a CCDA. QRDA1 is individual patient data, an individual patient, and it's data relevant to the measure, to a measure, right? So if you've got 100 ECQMs to report, you've got 100 QRDA1s to deal with. QRDA3, of course, Kevin went over this, is the whole population of patients. Sometimes I question the attribution, like if you're looking at QRDA1, what's the time window you're looking at? Because we see different time windows coming from different EHRs in that format. So time window, speaking of, for CCDA, and by time window I mean starting now and looking back how long, or does it start at the end of the last calendar year and look back a year? You know, what is the time window of data available there? In our CCDAs, of course, we have the clinical visit summaries, sorry I got that backwards, that are episodic. We have the transition of care CCDAs, we have the VDTs, the patient portal driven CCDAs, and the historical CCDAs, which we take into the Health Information Exchange, which have all the data the system can regurgitate on the patient for the full length of time. QRDA1, we're finding the time window varies, and it depends when the measure was pulled, but some EHR vendor products that we pull data from say, well, meaningful use says you measure on a calendar year basis, and so you can pull the file from December 31st back to January 1, and that's the file you got. Others will let you pull it from today. Let's say today's the end of the first quarter, so it's March 31st back to January 1 of that year, but that's the considered window in it. And so this introduces some variability into using the QRDA1 files that we hadn't expected when we started doing the more manual measure process. And then QRDA3, I presume, is the same as QRDA1, but I'm not absolutely certain about that. Oops, sorry. Data scope. All the MU data set requirements are in the data scope for CCDA, and that's expanding rapidly. And my sort of recurring message to ONC and anyone else who will listen to me is we need to add more stuff to the required meaningful use data set. The most common discharge in America, for a newborn, has no data in the CCDA that's required, no vital signs that are required, right? So that ought to be there. But QRDA1s really only have the variables relevant for measurement, and in many cases, they're variables that you and I as clinicians wouldn't recognize. It's a SNOMED form of a diagnosis that we just don't know. It's a SNOMED form of a procedure that we are not used to and familiar with. And then QRDA3 uses those as well. Oh, and the QRDA3 content is really just the results of measures, numerators, denominators, that kind of thing. Potential uses, of course, a CCDA being a comprehensive file, you can do quality measure calculation if you work with it enough, but it allows for point-of-care decision-making, care gap analysis, transitions of care support. There are a lot of uses for that full record on the patient. QRDA1 really should be restricted to its purpose built, I think. It's good at that, but it's hard to make any generalizations because it specifically excludes a lot of data that would be relevant for decision-making. Data provenance, which is one of the hardest things to get at, and I talked about it with our chain of evidence slide, and I already alluded to the fact that we find editorial decisions are being made in the mapping of this checkbox to that code, this field to that code, mostly by EHR vendors, but sometimes by individual practices in their installations. And this introduces a degree of variability that, frankly, the payers we work with are not comfortable with because they're seeing things that they don't understand in some of the decisions that are made in those reports. And so my own performance on a quality measure went from 75% to 10% to 35% over a course of 3 or 4 months. And what was interesting about that is when we looked at the attributed patients, to me, it went from 4 to 350 to about 65, which is probably the right number for my little 1/2 day a week or every other week practice. So, so it turns out that the attribution piece in measures is really important to understand. The way ECQMs are built, attribution is baked into the measure, right? The very first question in almost every ECQM is, who has the patient had a visit with, right? And that's so that within an EHR environment, you can determine of the 50 doctors in the practice, who does this patient, whose denominator does this patient fall on? Whose list does this patient fall on, right? And so one of the editorial decisions we like to make in our community, if everybody agrees to it, is we ignore that step. Because it doesn't matter at the community level. We do attribution a different way, right? So we ignore whether they had a visit or not. We're interested if they had a mammogram, right? So, and so I already talked about the editorial decisions. The validation of measure performance, and this is one that sort of as a measurement, as a numbers guy, I'm pretty concerned about. And that is, with CCDAs, you could potentially validate a large data set. And in fact, we have implemented the quality measures in Pop Health, and then we downloaded the 56 patients or 57 or whatever it is and test against those. But those 57 patients to test 100 measures, in my opinion, doesn't really get it done. It doesn't test every branch in the logic, and it doesn't do so with enough volume of patients to be assured that they're correct. And I know here that you guys have the ability to generate some big populations of patients, and I also know at NCQA that they have a measure certification program where they'll give you about 20,000 patients that test across those 20,000 patients every single branch of the logic in any of their measures. And I think that's the level of rigor we've got to get to if we're going to really be able to count on these measures and report on them. So again, QRDA1 right now, if you pull the QRDA1 file, the buckets have almost been defined already by the way the vendor puts data in those buckets in the QRDA1 file. And so the vendors have been certified on 56 patients. The EHR vendors have been certified on those 56 patients. I think we're going to want to raise the bar on the level of rigor there to get it done. And then the ability to support measures, and this is where CCDAs fall down because they weren't purpose-built for measures. They have to be tuned, as I just spent a lot of time explaining to you or showing you, and they have to be worked with. But the data in the CCDA is gathered and reported to us in a very natural way, right? I'm seeing patients, I'm checking boxes, documenting notes. I have no way to game the system, one patient at a time, to work with the numbers to make them show a result I want. I actually have to do the work to make that data come across. So I like the CCDA for that reason, and I think it could be expanded with the data from the QRDA1 to make the most robust picture of measurement, for measurement, but also for all the other use cases. And then the other two, of course, are purpose-built for measurement and will get you the result. Then you've only got to worry about provenance and testing and the other pieces to know whether it's a true answer or not. So I'll stop there. Take any questions. Okay. There wasn't a big clock down here, so I didn't know. There was a big clock yesterday. Oh, it's right there. Uh-oh, here we go.
I would just going to thank you and make a comment. I mean, I don't have a personal passion for any particular standard. But I will say that part of the reason the government chose QRDA is there's a commitment to not having more data than we need as the government. And so we don't want to have all the data of all the healthcare in all the country in some big database in Washington. We're very clear that we don't want that. So we have intentionally picked for the purposes of data sent to Washington the narrowest definition of the data that is necessary for quality measurement and quality reporting, which is why QRDA is what we picked. Mm-hmm. That doesn't mean that other standards aren't great for other people and other places and other purposes, but for our needs to make sure we minimize the amount of personal health information we collect nationally, that is the choice we've made. But I agree with the rest of what you said. I will say that a nuance that a lot of people miss, but is that there are actually two different meaningful use rules. There's a Medicare meaningful use rule, the one that applies to the providers, and then there's the ONC certification program rule. And that rule, the 2015 certification program, is not affected by the MACRA legislation. It's an independent set of rules that are working their way out. In the newest version of that, there's much more robust testing of the QRDA, and those testing tools have just been released, and that testing will start sometime this summer. You won't see the impact for a couple years because there's this big lag between when the policy comes out, when the vendors can actually build, when they can actually get into test, and then when they can actually put those systems into the practices. But we agree with you, not enough tests, not enough robust testingness, and so that has been a commitment and a part of the newer certification program.
Great. So if I can just respond real quickly, yeah, I appreciate the need to, of course, HIPAA requires that we send only the minimal data necessary for use. But if we minimize the data too early in the process, we lose all the secondary uses of that data, right? So to me, the minimization step should happen at that last point before it goes to the government, and not at the very first point where we're gathering the information, because then we lose all those additional use cases. And I know Kevin and I have talked about that a lot, so it's not even a point of contention. But one of the things I get asked a lot is, well, how are we going to increase interoperability in this country and make sure that wherever a patient gets care, or wherever decisions are made about their care, not just that they're physically present, but where decisions are made about their care, the complete longitudinal medical record is available. The only way, one of the ways I can imagine to incent that is to start doing measurement at that community aggregation level. Start allowing or requiring even that there's, or how about this, valuing more highly measures that include data from multiple sources. Because then you create an incentive from the top all the way to the individual practice to make sure that they're interoperable at the community level. I've been beating that drum for a while, and I'm hoping we get somewhere with that. Any questions?
I have I guess a comment and a question. And one, I think the Category 1 is a very nice thing to send to payers, because it clearly does the same effect that it has for the government. I think it has for payers, and it takes away some of the ambiguity that many states and groups have about, well, what can go to the payer, and there's a nice clean line there. But I want to underscore, before that filtering happens, it really has to cross multiple sources. I mean, I think that's really something that people haven't really thought through yet, that you've clued into. The second piece was, we've been trying to intercept the ways that people send supplemental clinical information now to everybody. And they go back a long way from some of these systems now, and are now about the task of really trying to figure out how might we generate QRDA 1s from that historical supplemental clinical information, with the idea that a big chunk of this journey is to actually begin to train the payer community how to actually use QRDA 1s and that whole space, because they've been doing this proprietary thing for so long. Do you have any comments on that side of the equation, and kind of putting on some of your NCQA hat, because I know you sort of got vision into that space as well?
You know, it's and in full disclosure, I'm on the board of NCQA, so I'm going to try not to divulge anything I'm not supposed to from NCQA, and at the same time tell you what my own opinion is here, if you don't mind. You know, we've had this period of time where the measures are, you know, the certification of measures in the ECQM space had only the 56 patients, and NCQA took a look at those and said, well, for our measures, we can do a lot better and provide a much bigger data set. When we are looking at the opportunity for generating measures that are claims-based and clinical-based, one of the things that, and this is again my own opinion, not necessarily where NCQA is going, I feel like we're narrowing what we could accomplish, and forgetting about other important data sources if we build our quality data models only around the value set in the context of an EHR and another set of value sets in the context of claims data. If to think about that chart I had a moment ago on the screen about the value sets, I would really rather have the value set of acute MI, and if you're dealing with EHR data, these are the codes that work. If you're dealing with claims data, these are the codes that work. If you're dealing with data from a homeless shelter or from Medicaid or from any other pharmacy, all these other sources of data that are relevant for patient care, these are codes that will work to qualify for that value set in a very concrete way. I feel like that's where we need to go as a country in order to account for social determinants of health and all these other critical things. So we need to expand our thinking on that process. So I don't know if that answers your question, but
It pretty much says we have to do that separately with quality someplace.
right. There has to be a staging area. Yeah, I mean, I think you in the notion of, I mean, if the principle of sending data to the payer is the minimal set, the principle of sending data to the staging area is send me everything you can for all the various use cases that people have that they want to drive, care gap analysis and risk stratification and all the other things that are possibly necessary there. So that's kind of the way I'd approach it.
So this question is for both of the last two speakers, Dr. Larson and Dr. Kendrick. A few years ago when Tim and then Jason roped me into this quality measure space, I kept hearing QRDA 1 and QRDA 3. And so then I started having these flashbacks to many decades ago in the first grade. I had this vague memory of something being between 1 and 3.
Right.
And I started asking, what about QRDA 2? Why is nobody talking about that? So I Googled and found out that, I think Mike Taylor helped me with this too, that a QRDA 2 happens to have as a side effect a patient list for a provider. And so you talked a lot about patient-provider attributions, and we talk a lot about ACRs, and we said, wow, if we could get the automagical from within the embedded, EHR API calls, QRDA 2s coming out on a frequent basis, that could help us automate building things like the active care relationship service, and you do attributions your way. And so we talked to HL7 because the QRDA 2 was not complete yet, okay, the standard. And they said, well, you could use it that way, but it's really intended for quality reporting. So I'm just interested in your thoughts on implementing what I just described nationally so that everyone who needs patient-provider attributions can get them weekly, monthly, whatever, automatically from EHRs using QRDA 2s.
You go ahead, Kevin.
So
I've never actually seen one.
The QRDA development started before meaningful use, but its implementation and I think current discussion has been driven by what's in the meaningful use policy. So in meaningful use stage 2, we committed to QRDA 1 and QRDA 3, and that was the point, I think, at which QRDA 2 lost steam at HL7 because there was so much steam put in the sails of QRDA 1 and QRDA 3. The 4.5 years I've been working on this, people have talked about the opportunities of QRDA 2 and how fantastic it could be for us as an industry. For those of you, the way I think of it is it's a spreadsheet. So if QRDA 1 is like a form for each patient describing the data on their measure, and QRDA 3 just says a numerator and denominator by a provider, QRDA 2 in my simple brain is a spreadsheet that has, here are all of the rows of the patient information, or the patients are rows and their data is the columns, and it's one provider. It's still XML, so it doesn't really look like a spreadsheet, but the data would be sort of easily put into that format. But having said that, it's driven by HL7, and so until it's actually what's called a balloted standard, until people have actually done all the work to do all the specification, do some testing and some implementation, and then get a group like HL7 to say, yep, we think it's ready to use, it's unlikely to have any uptake. So that's just a matter of a sponsor and volunteers willing to do that kind of heavy lifting work and testing. To date, the government hasn't invested in it. I haven't heard any word that the government's investing in it anytime soon. But I think that type of provider file could either be this, or it might be a fire resource. I could imagine, the fire that's happening next door is looking to describe things like that in a way that is not exactly QRDA, but could be instead of a push, it could be a pull. And I could query for what's your current provider attribution file, and I want to pull it from you as an organization.
The fire resource for care teams is sort of the inverse information. Instead of one provider and a list of patients, it's one patient and all the providers on the care team. It's the same information, but inversely, and you have to collect and parse it differently.
So just to zoom out for a second to the whole point of that discussion is we need to do a better job of attributing patients to providers and teams, right? Or we've got to be able to make that attribution. And so we find that the appropriate segment in the ADT file helps us with that a lot on an automated basis. And as I described yesterday, we use an algorithm to apportion those patients. So we find it a lot easier to tie patients to doctors or providers than we do to tie doctors to organizations and systems, which is really the other critical step. And so I think we're also seeing CMS recognize the challenge with current attribution, particularly in the payment side, because in order to have a patient attributed according to typical payer attribution methodologies, somebody has to get paid for it, right? I file claims and therefore patients can be attributed to me. But in value-based payment models, we want to encourage providers to do things that don't trigger payment. Do more phone calls, do more group visits and things that deliver care more efficiently. And I noticed in the CPC Plus FOA, they actually called out the notion that they're not particularly happy with their current attribution logic. And when they start to pay, especially in Track 2, upfront 65% of the E&M payments, they're going to have less money to drive attribution to those practices. So just by being in Track 2, the practice could be risking losing attributed patients, according to CMS's algorithm, right? So that's the kind of thing that I think we need to think through. And I don't know it sounds like the Type 2 file could help. If we could query it and get it, I'm sure we would still find a lot of providers with the same patient on their list, which we would want to resolve depending on the attribution model. But it could be helpful. We are getting it in ADTs right now. Thank you guys for your time.